Welcome to our session on Beyond Rare Redesigning the Rare Disease Landscape, organized by Voice of Healthcare on the occasion of Rare Disease Day. So, today we are discussing Welcome to our session on Beyond Rare Redesigning the Rare Disease Landscape, organized by Voice of Healthcare on the occasion of Rare Disease Day. So, rare disease need, I think, a new approach, earlier diagnosis, better awareness, and simple access to care. By using better data, teamwork, and patient focused solutions, we can move from delayed recognition to timely care and improve quality of life. Let's take a digger, deep into this discussion and discuss with our panelists for today's session. Join me in welcoming Dr. Professor Jayesh Sheth, Chairman, Foundation for Research in Genetics and Endocrinology, Institute of Human Genetics. Welcome. Dr. Prasad Narayanan, Lead Consultant, Medical Oncology and Hematology, Manipal Hospital. Welcome, Dr. Prasad. Mr. Saurabh Singh, co-founder and director, Rare Disease India Foundation. Welcome, Mr. Saurabh. So my first question is for Dr. Jayesh. Dr. Jayesh, what exactly do you think that India's diagnostic pathway breakdown is now for rare diseases? And is it at the level of, say, primary, suspicion, referral system, or genomic infrastructure?
See, I can go back to some 2 decades back when the genomics was not so much in the news. The rare disease were very difficult to diagnose, or one has to take a good pain. But now I can say that the rare disease are no more rare. No doubt, still we have not reached to the rural part of the country, but at least in urban part of the country, the rare diseases are not new in India. And the diagnostic challenges are, yes, they are there because there are still a pocket where they offer the diagnostic facilities, but mainly on in all urban part, the diagnosis is available. So diagnosis is not a challenge. The challenge is awareness, and awareness not only among the doctors, even among the patients and among the doctors as well. Some of the fraternity in medical field, like for dermatology, I can see from cardiology or the nephrology, there are still, I think, the less awareness. Or from my experience, I can say that everybody thinks that a rare disease means is a pediatric, yes. So they cannot happen to the adult. So mostly the rare disease patients are goes to the pediatricians or to the geneticist. And but with increasing awareness and genomic technology, especially NGS, is like a one switch that make the diagnosis. So if you don't understand any disease, people just order for the whole exome study and get the diagnosis. But then there is also there is a lot of holes in that, ups and downs in that, because whole exome study it may give a false alarm, false positive, false negative both because of the technical limitations of the study. But I can say that in India overall, there is a momentum. And that you must be aware that the government of India, as in 2021, first started with the National Rare Disease Policy. And under that policy, they divided the three groups. They are provided the treatment up to cost of 50 lakh rupees. It's a great achievement. So at least the something has started, but still the challenge with the therapy. So I think therapy in the sense of this therapy are very expensive because majority of them are getting from the outside, from the Western countries. It runs in crores of rupees, like for SMA. even for DMD, many of the storage disorders like lysosomal storage disorders like Gaucher, Pompe, many others. So, but as you know that the like disease like Wilson disease, alkaptonuria, tyrosinemia, nitisinone is now available in India. So that has made a very affordable price. So because of this therapy availability, the doctors have got also interested in diagnosis. So the diagnostic momentum is there. Yes, but still the rural part need to be addressed and need to be covered up. How we have to cover up that I think uh, we can talk in the other questions part later on.
Right. Right. And Dr. Seth, I think diagnostic is very important, and I think we should clinch the diagnosis as early as possible. And if you were to,
Yes,
redesign India's diagnostic algorithm today, what structural reform would you implement to ensure genetic testing
I
becomes the
would
first
see.
step?
Yeah, we have to keep in mind because the technology is available, but technology 60% of the people in India they live in poor rural area. So technology has to be such which is affordable also. It's not only the availability because people who are maybe 2% looking at the population size, 2% means a lot. Those who can afford and then you do for the whole exome study or whole genome study. But what about the rest of the things? So what India needs to have our own indigenous affordable diagnostic technology and which we are many of the centers, and we have patented two technology for rare disease diagnosis, which for the genomic based technology, and one is a screening simple, just looking at the color of the plasma and adding some substance, you can identify the rare disease like mucolipidosis, or by genomic technology, where the 29 common the lysosomal storage disorders by known as a MIP, molecular inversion probe based NGS, which is a patented also, and now I think soon it will be commercialized. Still, so affordable technology is very important what India needs to do. Genomic technology is available, screening technology is available, but still we need to develop a lot of biomarkers. Like biomarkers for like somebody is coming with the neurodegenerative disorders. And at the same time, he has other organ involvement also like hepatosplenomegaly is there. You don't know what is wrong as whether primary site in the brain or primary site is the liver or spleen. So in such cases, we should have the clinical pointer. I think now we already have a clinical pointer for many rare disease. The most common, like for thalassemia, sickle cell, we have the pointer. We know that when the hemoglobin is low, anemia, and MCV is low. I think this is a very simple marker. Even for DMD, muscular dystrophy, TPK is very high. Just give the indication, yes, something wrong with the muscles, and then you go on looking at the specific diagnosis. Same with the child coming with the huge spleen and the liver and but the higher difficulty in walking or child having the gaze palsy. All these are the pointer like child usually with the huge spleen and liver, with the primary focus is maybe Gaucher disease where the ERT is available, or maybe the Niemann-Pick disease where the substrate reduction therapy. Now I think in India is trials are going on in India itself. So same way for Niemann-Pick C. So these are all very rare disease. But even for SMA also, you know that the SMA, the Spinraza is very expensive, 16 crore rupees. But now India has started with oral therapy, so which is affordable treatment for even for SMA. We still have to look at the benefits and the clinical outcome of these drugs. But yes, the treatments, more and more treatment available. Even government also now taking an interest, like for ICMR and DBT, special calls are given that you develop the indigenous therapy. You diagnose it that because of the NGS technology, we diagnose more and more number of the patients every day in and day out. But then what about, because many doctors feel that okay, we have done the diagnosis, but there is no treatment. If I talk for the Huntington, which is an adult onset disease, but if there is no treatment, then doctor feels oh, unnecessarily we are putting a stress to the patient. In fact, we are not putting a stress. We are telling what is there, so he doesn't go around and then everybody trying to find out the cure. We may go to other doctors, other field, and then try to they unnecessarily going on with so much stress, so much tension, and financial burden also. So that I think in India challenges are there, but is the government is taking a very enough steps are there, and then even through the task force, there are many task forces there. You may be aware that first task force was started in ICMR by 2015 and it paid to 15 to 18. That has made it possible to understand the burden of the lysosomal storage disorders and to understand the molecular epidemiology of the disorders. Even identify the founder mutations, identify certain pocket. Like in Gujarat, we have a high amount of the high incidence of the Morquio disease is there, Morquio A, because there is a founder mutations in one community. Tay-Sachs, which we feel that which is Tay-Sachs is more common in Jewish population, but in Gujarat, in one community in Saurabh area, they have a founder mutations for Tay-Sachs disease. So same way there are many founder mutations other bases also. Like Gaucher is most common in India because Gaucher we all have the pseudogene, we all have the heterozygous status in the pseudogene. That is why the L-typopopy is one of the most common molecular marker for Gaucher disease in India. So now many things we know and more things now getting evolved and now more focus on the therapeutic base.
Right, rightly says, sir. There are so many rare diseases which are
Oh, there
being
are
mentioned.
7,000. There are 7,000 rare diseases are there. So India alone has 80 million. Burden is 80 million. And it
Right,
nearly 75 to 80% have a genetic component. But slowly, I think we are not, it's not that the government also putting an effort, the research organizations, scientists, clinicians, is a very multi-system approach. And I'm sure that by coming, I have seen the journey from 2000 to 2025, where people were not aware when we published first paper in 2004 in Indian Pediatrics say that lysosomal storage disorders are there in India. People were surprised, कि क्या, but maybe researchers, so it's just, I think, publishing. But no, in 2013, we found it in JIMD. We published it again in last series of data showing the storage disorders are in India is there. They are no more there. And then the lot of advocacy group and the ICMR has formed the task force. So now we know that where we stand for LSD information, all lysosomal storage disorder information is, I think, almost everything we know now. Same way for many other rare diseases like major with the neuromuscular disease or immune error of metabolic disorders. So therapy is also available slowly. So that is a better advantage even for prevention also. When we don't talk for prevention, because obviously there is no treatment is there, but once you diagnose them, you can make the precise counseling to the family. What is going on wrong? And if you identify that particular wrong things, how we prevent to go in the next generation? Because majority of these are autosomal recessive.
hmm,
When we talk for autosomal recessive, they have the 25% recurrent risk in the next pregnancy. So
right,
how we can identify during pregnancy and then lessen the burden in the
right.
society to the family.
Right. Right, rightly said, sir. And I think we should move on to certain rare cancers as well because they are also
Yes,
prevalent and very difficult to, pick them up. So, Dr. Prasad, since you are a practicing medical oncologist, you must have come across and you must have seen that patients often undergo multiple treatments before a correct diagnosis is made. So, from an oncologist's perspective, what clinical or pathological red flags are most commonly overlooked that delay suspicion of a rare malignancy?
So, when we talk about this diagnostic Odyssey in cancer, why we are failing these patients. So, as you rightly said, patients undergo multiple treatments before they come, and for a long time, it was like tuberculosis, which was patients were being treated for tuberculosis when the primary disease was malignancy. That awareness has come. Now we don't see that many patients getting treatment for tuberculosis just like that without getting a biopsy. But having said that, we should also know that there is a possibility of a rare cancer, right? As Dr. Seth said, with our population, even if the incidence of a cancer is less, when you see the number of patients that are diagnosed with that cancer in the country, that's huge actually. Recently, we had a discussion where we were talking about biliary tract cancers, for example. Nobody talks about biliary tract cancers, but they are one of the main. A significant number of patients get diagnosed with biliary tract cancers. They get treated for gallstones, they get treated for something like that, and then there is a definite distribution of this group of patients in the gangetic belt. We don't have much awareness uh, or a referral pattern for this, so that we get to see these patients early. So when I view from an oncology lens, the delays, there was a study which said that a diagnostic delay for a rare cancer in India is to the tune of 6 months, which is huge. We may not even have a patient survive after 6 months if it is a cancer, actually. So the overlooked red flags, one is the atypical demography. So that antenna should be high. For example, if I can put in perspective, sarcomas, sarcomas like a pediatric sarcoma, like any wing sarcoma, it can happen in an adult also. It's not necessary that it will always fit into that particular age group. So that red flag should be there. And if you want to diagnose, suppose you want to get the mutation test done, this is not available in all centers. And that does not mean we should not diagnose them. So if we miss the diagnosis of an Ewing sarcoma and treat it like any other sarcoma, we are not going to get the correct outcome. And these patients would have got some treatment before and then they come to us. Another example is about sometimes patients might have just presented with some odd symptoms like hypercalcemia, and evaluation might lead to a diagnosis of malignancy. So even common cancers are mistaken, but you forget about rare cancers, actually. Then also we should know that it is not necessary that the disease always follows our usual protocols, right? Ovarian cancer can cause GI bleed. We had a patient who presented with GI bleed, and final diagnosis from the biopsy from the stomach wall was that there is a primary in the breast. Actually, this thing happens. It is not that these are unknown, and once we are able to have that high index of suspicion, only we will be able to get them. Then also, when you are treating a cancer, assuming that this is a common, like a testicular tumor or something, if the patients don't get the required response in the first line, that should immediately raise the antenna. Are we missing something? Should we sequence this? Is there a mutation which can be targeted? So it is always about the awareness about in the primary treating team in identifying them. And also one thing which I would emphasize is that more and more we are getting I mean, the importance of a multidisciplinary team seeing a patient. We are all bogged down by the volumes that we see. So the common malignancies which just flood our mind, and the OPDs will just flood these rare cancers, and they don't get what they deserve. So even if you want to do an awareness campaign, for example, you will not get anything if you want to do an awareness campaign for a glioblastoma multiforme, for example, which affects a lot of people, but you will get a lot of support if you are doing a breast cancer. So we should not just isolate cancers. Actually, every for a particular group of patient or a particular patient, whatever happens to them is the most important thing. That is the most common and the most important thing. So basically, to answer your question, the red flags are that as Dr. Sheth said, why should we diagnose if there is no treatment? That is not right. There will be treatment. Unless we diagnose them, how are we even thinking about treatment? And many of these cancers are curable when you diagnosed early. Also, some of the rare cancers, for example, one of the sarcomas called dermatofibrosarcoma. This sarcoma can be treated with a tablet which is available for less than 1,000 rupees a month now. So this it's important to diagnose and refer to them to the particular center and have a uh, uh, a high alert when you see something which is not normal, and that will help us in diagnosing them. This is the most important red flag. Another thing which I would want to mention is the quality of the labs. So there was a survey which said that only 15% of our labs are CAP certified. I think that should improve. All the labs should be CAP certified, right? We should not have a situation where we cannot trust the report which comes from a lab, especially when you are talking about a rare cancer. These are the red flags which I would mention in this.
Right. Right. So rightly said that many of the common cancer may present with rare symptoms, and rare cancers are misdiagnosed, and they are mistreated. So I think the awareness is required. We have I think the diagnostics available. Some treatments are also available, but misdiagnosis is something that is of the concern. So my next question is for Mr. Saurabh.
Manisha, can I add one point here to Dr.
Yes,
Prashant?
yes,
Prashant,
yes.
even for cancer, like the Lynch syndrome, you may be aware that the Lynch syndrome are not known much but they are colon cancer, and we have been studied, and very soon I think we will come out with a study. We have founder mutations for that. One
I
part
know.
in Gujarat, in
Yeah.
Siddhpur, every family has got a called the Lynch syndrome, and you know that the Lynch syndrome, there is a treatment, is simple aspirin treatment, and then the raw banana. The, there's a paper has come out in Lancet. Dr. Sheth was a part of the study. Even raw banana, in 60% cases, there is a recurrence risk reduced just for simple therapy. I just want to, this is just, I think, this adding to the point.
Yeah, so
Right.
since you discussed Lynch syndrome, that is something which we also keep our, we also, whenever we see a young patient coming with cancer, for example, a GI cancer, colon cancer, because if we have Lynch syndrome, first of all, the cancers that occur in them are early stage. Secondly, they respond beautifully to immunotherapy. So this is one reason why we scrutinize patients for Lynch syndrome. These tests were not available before, but now they are available at most of the good labs actually.
Right. So moving on to, I think, families. So, Mr. Saurabh, what does the diagnostic uncertainty phase truly look like for the families if we discuss it like emotionally, socially, and financially?
Yeah, actually, really, this is a very means connecting questions with the families and the parents as well, because you know what happened. The it's constant fear and confusion without diagnosis always there with the parents, because they have to multiple times visit the hospital, and they have to go one doctor to another, one test to another, one city to another city. So they have to every time moving here and there to get to know that whether the son or the daughter is suffering from which disease, and it takes too much time. The emotional stress and helplessness is always with the parents actually. The social isolation due to the lack of awareness, because nobody knows, because they connect with the normal diseases, and the parents once know the disease, they feel isolated. They don't know what is the future of their child. They rest they are living in uncertainty. Actually, they already, before the start of the treatment, they are already financially exhausted for the repeated test every time. Anxiety about the child is always there, because of their future, because they don't know what will happen with their child. So a delay caused by systematic gaps are also. So these are the complete things already there with the parents, because they feel that they are the unfortunate people. They have got this drug in his family. So this is very painful actually. The society must understand this type of thing. And what how we can do that? We can do it through awareness, continuous awareness, because uh, I am also a parent of a child. I lost my son 4 months back due to this rare diseases. You know what happens? One, if you will not start the treatment on time, the disease will progress. And after giving the therapy also, the costly medicine, because it comes in crores of rupees, it will not the child will not survive if the drug will not given on time. So this is actually the current scenario, and they are feeling this type of
Right. Right.
problem in rare
Right.
diseases.
Right. I think this is much needed that we have to have the emotional support for the family and definitely the diagnosis and the financial support. This is what is required for them as well. So, Dr. Seth, what do you think that you are into research, right? And what do you think that should there be national genomic registry or rare disease biobank to streamline data-driven decision making for rare diseases, and how do you think that this can be implemented in India? Dr. Seth, please.
So
Sir,
you're
Sir,
you
you are
are.
muted.
on mute.
Yeah.
Yeah, you know that the ICMR has got the already 7 years now. The rare disease registry is already there in existence, and I think this year is the last year, 7th year, and they focuses on the lysosomal storage disorders, certain neuromuscular disorders, the the primary immunodeficiency syndrome, and so it is already there, and that will at least make us to understand what is the actually burden of the rare disease, and talk about the biobank. I think very recently, only we just published the papers on biobank for rare disease, especially with lysosomal storage disorders. That was the project we started in 2021 by the Department of Biotech, which has funded us. The DBT, Government of India, has funded, and we just completed that, and that has stored the now 570 well characterized biosamples of the patients affected with the red lysosomal storage. This is only for lysosomal storage disorders because the I think among all 7,000 rare diseases, we know we have very good clarity about the lysosomal storage disorders because of the task force by the ICMR, and several research has been carried out. So we know that what is going on, which is the most common, what is the burden, what is the molecular signature, what is the screening program, where it is more commonly seen, all this available. So registry is already there, but yes, I will agree that registry is open only to the selective centers, so there are many parts of the country are not included. And second is registry is not open for all rare disease, is only limited. They're limited to certain disorders only. So I can say that around certain 40, 30 or 40 disorders. So that not the reflect the actual rare disease burden. But so India, I'm sure that after this, somehow the DBTO or some organization will definitely start this national registry, and it is a requirement for the national registry for rare disease, where the portal, I think, maybe in every state, the centers, some centers are selected, and then they just log in and they put wherever with the diagnose, they enter that patient's geographical data, the oncological criteria, and the final diagnosis. So it is a requirement. But yes, ICMR has already started it, and they're going towards it, and I think soon they will have a publications also about the experience of the ICMR for the rare disease registry program. And as far as the biobank is concerned, just I think we had the paper in Orphanet Journal, and developing that 2 or 3 centers are already using those biosamples for development of the biomarkers focusing on the lysosomal storage disorders. Some centers are also developing the therapy, especially substance reduction therapy, using this biobank. And our own group also, we are focusing for gene therapy, at least the proof of concept and the preclinical trial for MPS1. So there is still a need to have a biobank for all rare disease, and I'm sure that in coming years we will have that because there enough awareness is there, enough knowledge is there, and lot of getting patients are getting diagnosed. But again, if we depend only on the government, it is a mammoth task. So it has to be linked with the Aadhaar card. I think that's a government. I think let it come. How it has to link to the Aadhaar card, so then all the data needs to be in uniform way. The entry has to be very uniform way. So then only it has a meaning. Otherwise, very haphazard and wrong diagnosis can be done. So then we'll not have actual ideas. But
Right.
if you ask about the burden of the rare disease in the country, I think in our last year paper only, the burden of rare disease in India, we identified some 335 rare disease. That was the study of 22 years. And among them, again, the neuromuscular IEM group was the most common one. So yes, there is a need and for the
Right.
same.
Right. Right. So this is important, and I think biobanks are really important for discovery of biomarkers, as you said, as well as for the therapeutic thing. So, Dr. Prasad, what do you think that there may be lesser clinical trials going on? How challenging is it for you to manage rare cancers in the absence of these large clinical trial or India specific guidelines?
Right. So I can maybe I can put this in perspective by discussing 2 3 things which in the last decade has evolved in the country. For example, we have had the information about the hereditary breast cancer susceptibility gene called BRCA gene. So I remember sitting in a discussion about 10 15 years back where uh, the person who invented this was there in the conference, okay, and he was being told, "Oh, this is not something which we should discuss in India because who will do any test to identify BRCA gene and then susceptibility in this country, and who will come for a prophylactic treatment. That has completely changed now. The test is available for few thousand rupees. Almost all patients of breast and ovarian cancer get the test done. Their families come to us. We counsel them. Some of them get medical management. Some of them get surgical management. So when it is only about creating the discussion and the awareness, and what you are doing now, bringing people together from public private partnership and discussing this, that makes a difference. Another thing is, when we heard first about immunotherapy, we thought this is not something which will never come to India, but now we have India's own immunotherapy. We have CAR T cell therapy. If you had told me 2 decades back when I was training that I will be involved in, or we will be seeing CAR T cell therapies being given in our country. We have India own manufactured CAR T cell therapy. We have multiple trial participation. So basically, it is about uh, having access to cutting edge research, and in all levels. We should never become redundant, and we should never accept mediocrity in our life and our education. Now, when you talk about beyond diagnosis, we are now talking about the treatment access, care fragmentation. Definitely there will be a problem, right? It's a rare disease. We will not have that 2000 patient phase 3 randomized controlled trial which shows the outcome here, because there will be not trial data. But we have to extrapolate from the available data and our own wisdom, and that is how what separates us from AI, right? We don't just rely on what is published, and we have to go with our wisdom as well, in terms of deciding what is the best way of treating patients. So it is challenging. I don't disagree with that. And another challenge will be that we will know that there is a particular treatment or a drug which is available for this disease, but we may not have a single Indian data, because none of the Indian patients were part of these clinical trials due to the lack of availability of these trials in the country. And then we know this drug is available, the drug can be brought, there is a family or there is a support program which is bringing. Then we have another bottleneck is the CDSCO, which will we have to get an individual approval. So these things can actually and especially in a situation like a malignancy, sometimes we don't even discuss this with the patient, because there is data to say that the patient's quality of life and overall survival comes down if they know there is an available treatment, but I am not getting it because of so and so reason. So that is another challenge that we face. So I think the bottlenecks are there. We are trying to solve these issues, but they'll always be there. Having said that, data scarcity doesn't mean that there is no data and there is no treatment. So when we pooled centers together, when we have, this is the era where we can access a multidisciplinary team virtually. So we do virtual tumor boards. We have our own patient support groups, and our own cancer treatment groups as well. So we treat patients, we give information, we share information. Now the CTRI website, the Trial Registry of India, we have access to that. Even patients are searching this trial. I had a patient who traveled from Hyderabad to be a part of a clinical trial in Bangalore. So these things are happening. It is not that it is not happening. The internet has actually exploded the access to these treatments and information. So I think this will change, and maybe few years down the line we will discuss this in a different way. So basically, to answer your question, I'm not denying there is a challenge, or there is a problem of lack of availability or access, and also the financial toxicity. But I'm seeing changes here in the last decade or so, and I'm sure that this will improve in the coming years.
Right. Definitely. So, Mr. Saurabh, while the National Rare Disease Policy, provide funding options, as we have seen, and families, they do often struggle, because of the implementation gap. And what do you think? Where is the bottleneck?
Yes, actually, if we talk about the national rare disease policy, the first national rare disease policy once came, there was a some problem. Means there was a APL and BPL criteria was there, and it was only 20 lakhs rupees support for one time. After that, this national rare disease policy revised in 2021, and now the national rare disease policy having 50 lakhs rupees support for one time, but the rare diseases are categorized in three different groups. And the last one means group 3 diseases involves those patients having lifetime therapy with the high cost. I mean, the cost comes in crores of rupees every year. So government is supporting with 50 lakhs rupees only, but they are not supporting lifetime therapy. But the major challenge is with these patients like LSD's patients, DMD patients, SMA patients. They are not getting any support out of this policy. So this policy, what happens? I mean, low awareness for policy at ground level, because people does not know what these policies are. So they have to understand what this policy, because patient has to go every time to the courts. And now the this policy is under sub judice in Supreme Court, and it is being heard in the month of March for the final time in Supreme Court. Then the patient group and the people will know whether these patients will be supported by the court or not. So these are the problems in national rare disease policy. But yes, once again, if we'll talk about the complete policy, this policy also says uh, CSR support. CSR can give their support to this policy, but there is no clear-cut mandatory direction to support this national rare disease policy, because government says government alone cannot treat all these patients because the cost is huge, our population is huge. We can understand, but it must be a clear-cut in direction to the CSR funding for these rare disease patients, because who will take care of that? Our article 21 right to life, it says it's right to life, it's our fundamental right. We must have to take care of that, because they are also the citizen of India, and they are isolated. If we'll talk about the government asked talks about in this policy that there is a crowdfunding portal. Government launched their own crowdfunding portal, and they said that this crowdfunding portal will be utilized for the treatment of rare disease patients. And anybody, I mean, individual or the corporate can give their donations, and they will get the tax benefit. But if you will see, this policy was launched in the 2021. We are sitting in the 2026. In last 5 years, this crowdfunding portal has generated only 5 lakhs rupees. I mean, 4 lakhs something. I have seen 3 days back. There was only 4 lakh something rupees was generated. It clearly indicates that the government has very less focus for rare disease patients, for group 3 diseases. So they must understand that these patients are also the part of our country, and they are also having some rights, legal rights, the fundamental rights. So these are the problem, and we can understand the financial challenges. So government must understand this. Yes, this is the problem actually in a national rare disease policy.
All right. So I think with the proper implementation and in future, I think the gaps would definitely be filled and be more accessible, as well as the financial
Yes,
support.
yes, right.
Right. Right. So, my next question is for Dr. Seth. Sir, as we know that
Yes.
we need, geneticists and counselors for genetic counseling, and we also know that we have to build the capacity. So, how can it be done if we want to build the capacity at scale, be it through curriculum or fellowship models or public-private partnerships?
The first thing I would say that still, though genomics is there, in medical curriculum, genetics is still not incorporated. This is the first part because these are the doctors who are going to see the patients. Still, the genetics is not the part of their question papers or the curriculum. It is it is an optional subject. So that I think government can do that. Second point about the awareness, it need a lot of awareness. Like today is not only rare disease, today is also the science day in memory of Sir T.V. Raman. So let the media, I think media has to be more and more provocative, more and the more aggressive in the campaigning for the rare disease. That these are the people like for DMD, for SMA, thalassemia, sickle cell. Yes, government has taken the mandate. So we know that see once government decides to work on it, they can definitely. There are many hurdles are there, many challenges are there, but they can do that. As far as the infrastructure is concerned, yes, we, as I said, first start with the manpower, at least the trained, the clinical doctors who knows the disease, what exactly there's something wrong. Like see somebody like a pediatrician. coming, the child is some family comes there, and the child is okay by 2 months time, and then suddenly he start with a neuroregression, and then child dies by around 1 year or 2 years of age, not diagnosed because he's in remote area. So doctor feels okay, there's something wrong, maybe some infection is there, and they label them as some infection or maybe some an encephalitis and put in. Actually, the underlying cause maybe the Tay Sachs disease because that we have seen in Saurabh region in one community, it is very prevalent there. So child dies by 2 years of age. So before that, they are not getting diagnosed even. So that is, I think, the challenge is there, awareness. Second point, the infrastructure, yes. The genetic diagnosis, but now we know that the BT has already started the Nidan Kendras in different part in the especially in the government centers. So at least patients can approach there and get the diagnosis. No doubt they are not becoming popular, and I have not seen any data coming out of the Nidan Kendra. Okay, what are the every Nidan Kendra, how many cases they diagnose, how many so that kind of the data if available, then we can make a comment. Yes, are they successful or are they remain just on the paper? They also started the Umid Center. Umid Center means like the like Narmada area where there's a lot of the Dang area where the lot of Adivasis are there where they have no means to approach the diagnosis. Those areas the government has started the program, and it is there in existence, but I doubt about the success. It is just because as far as the Nidan Kendra is concerned, I have not seen any data coming out. So we still lack about the facility to the rural part. Like somebody sitting in a rural area, and even simple sickle cell or thalassemia, they are reluctant. Not only that, even patients are reluctant many times with the social taboos. They are reluctant to get the diagnosis also because they say, oh, we'll have the people will put some blanket on them, and then they may not get like the social, not social boycott, but maybe the some social stigma can be there. So these all kind of the myths also are there for the underdiagnosed or for the undiagnosed cases. And the counseling, yes, the geneticist, we require the good molecular geneticists. Not only the clinical geneticists are meant to make the clinical diagnosis. Yes, the child is suspected. Then it comes with the different kind of the clinical geneticists, like we have the molecular the geneticists, who because mainly I think I can say that 80% load is based on a molecular study. So we require a very well-trained molecular biologist or molecular geneticist who understands the complications of the diagnosis, reading through all the 3 million letters and then make the proper diagnosis. Then third part, we need a genetic counselor. Genetic counselors we have in India, but I think we need a proper training because genetic 6 months course or 1 year course cannot become the genetic counselor because genetic counselor requires minimum 5 to 7 years of the experience. Then only they become a counselor. But unfortunately, in India, we see the counselors they're getting after the undergraduation or maybe the post graduation, they get some training or get degree and they become the counselor. So that leads to the very haphazard way of the approach to the patients. Or sometimes very frightening. Also, I see. So we need a good genetic counselors with a properly trained, properly certificated counselors or who are well experienced, maybe for 5 years, 10 years, 15 years experience. So these three categories we need. First, awareness among the clinical doctors, removal of the social taboos because we can see that your treatment is available, we can prevent it also. Third one, we need not only the clinical geneticists, we need a good scientist, a molecular geneticist, or good biochemical geneticist, because genetics again is a wide area. It's not only single, okay, you become a clinical genetic, so you can know everything. We require a molecular genetics specialist, we require a biochemical genetics specialist also, we require a cytogenetic specialist, because start genetic like in a pathology laboratory, if you do not if you have no facility for the blood sugar, your laboratory can't work because that is diabetes is day in and day out. Same way for when we talk for the genetics. The cytogenetics start with the chromosome identification, and that is called as cytogenetics. And that chromosome identification is a base of the any genetics lab or in any genetics the institutions. So that we require is trained manpower. I think in India and I think everywhere there is a problem with this trained cytogeneticists because it's a more of the very difficult technology. But now microarrays, the different technology are there, but still the gold standard is the cytogenetics. same way for molecular, same way for biochemical. So I think we are in the process. So now many of the geneticists are coming up. Many of the young students are taking biotechnology. Many of them are opting for the molecular genetics. They're becoming the bioinformatics or molecular genetics. So slowly, we are on the way. But still, I think we are building up. And you will be surprised also that very soon we will have the program of the maybe the 1 million genome sequencing in India. So I think very soon we will hear that. It is soon will be started with a national genomic data grid, and I will not talk in much detail about it because still it is not yet getting published, but yeah, soon I think it will be started. So that will have the proper Indian genome database with proper well-matched phenotypes. So it will have our own reference genome. Right now we use the reference genome of what is done in the Western countries. But now then we will have our own reference genome in India, so that will have a better diagnosis, more precise diagnosis in the country.
Yeah, I think this is much needed, sir, and let's hope that this happens in future.
Yeah.
So, Dr. Prasad, we know that there are certain orphan drugs. We know that you were talking about immunotherapy. These are not widely available and they are very costly. So, what do you think that what institutional change, is needed to ensure the continuity of care for rare cancer patients, rather than it being so fragmented?
So before answer this, I think as an oncologist, when I hear that we are going to have our own genome data of 10 million, is it people? Then
Yes,
it is
yes,
going to
yes,
be
yes,
like,
yes.
it
One
will
million,
be
1 million, 1 million.
for an
One.
oncologist gold mine. Actually, for us, it's a gold mine.
And
So
cancer is one of the focus in that, which is not yet
right,
because cancer is one of the focus. We
right,
very target cancer, diabetes are one of the focus in that.
right.
So I'm hopeful that that will definitely will be kick off.
So
It has not
com-
yet started. It's
right.
still in the primary stage of the organization because it's a very mammoth task to complete it.
Right, sir. So coming to your question, I think it's a very important thing. Now we are talking about the road ahead, right? How we can make a patient-centric ecosystem. That's the question. So we can take the example of National Cancer Grid, which actually has got most of the comprehensive cancer centers which have aligned together. So what we do here is that actually now we can get a very high value molecular tumor board opinion for a patient for no cost. Actually, this would have otherwise, if a patient had to travel to get this opinion from these many people, including a medical, surgical, radiation oncologist, pathologist, radiologist, then the molecular biologist, and geneticist and counseling, all this is available. And COVID was actually a great opportunity for us to realize the potential of this virtual connection. What we are doing right now is also that only. So basically now we have a lot of virtual molecular tumor boards which connect people. So if we have an issue where we are not able to get a molecular test done for a patient with a suspected Ewing sarcoma, for example, that can be shipped to one of these centers to be done, and many of these centers can do it for a meager cost actually. And getting that opinion and that information has made a huge difference. So that actually takes care of the access problem, because most of the clinical data or the clinical treatment can be provided at most of the cities now, because most of the tier 2 tier 3 cities have medical radiation and surgical oncology facility. It is putting together that high level tumor board discussion where these complex cases can be discussed, which was the challenge, which is getting sorted out now. Getting the drug availability, to give a perspective, for example, there was a biosimilar in breast cancer, which actually, before the biosimilar came, the access to that drug was 10% in the country. In 5 years after the biosimilar has come, it has increased to 70%. It is now part of the Ayushman Bharat program. So it is a game changer actually. From 10% to 70% in a country like India is unbelievable, and that scale is huge. So things will change, and the You can take the example of the cervical cancer vaccination. I mean, 5 years back, if somebody said it will become part of the universal immunization program, who would believe it actually? I mean, who would think that we will have a cervical cancer vaccine as part of the universal immunization program, and that too made in India? So things are changing, things will change, and COVID has actually been a boon to many of these things, because we realized our potential, and there was time to dedicated time and activity towards this, towards making some our own things actually, and we have more and more realizing about that. So then leveraging the technology, like as I said about a virtual tumor board, teleconsultation becoming legal now. Can legally give a teleconsultation through the, because the government has made teleconsultation legal. We can give an opinion, we can treat people actually. And so these are the things by which we can make the access problem sorted out. Now also, how we will make this you talked about immunotherapy, for example. So we have data that from Tata Hospital now, that is part of our own treatment paradigm, that we can we can treat low dose immunotherapy. So the same medication at a lower dose works well in Indian patients, and we have large 1,000 patient data which was published recently, that has decreased the cost by probably one tenth. So the Indian jugaad works everywhere, and that is how I think this will translate into better outcomes in all diseases, and cancer is no exception there.
Right, right. I think National Cancer Grid and now the National Genomic Grid, if this comes, I think the things are going to change, and we'll be discussing definitely these things in different way in coming years. My next question is for Mr. Saurabh. Should you think that the patient groups have formal representation in national rare disease decision making committees and have a proper representation? Mr. Saurabh, are you there? So I think there is some issue. Okay. So I have few rapid fire questions as well, which I
Can
think
can I can I
I'll
can I
ask.
have one
Yes,
addition to
yes, yes,
Manisha?
yes,
Because for
yes, yes.
the even every government hospitals, even government hospitals who start with a genetics department. At the moment, none of the hospitals have a genetics department except a few corporate. So at least
Hmm.
they should start some genetics department, and that is the beginning. So they will identify and lessen the burden. Not only that will help the maternal and fetal mortality burden much less. That will definitely help them. Cancer also is a big issue, and what Dr. Prasad said, I think he's right that even very soon we'll have the vaccines for men, like for Lynch syndrome. We are in the process, not yet, but we are forming because we identified the founder mutation for Lynch in Gujarat and developing the new peptide and then trying to look at it. So I'm sure that the more awareness, every government hospital should have a compulsory genetics department is there. Then only I think that will penetrate to the rural area. That's just I want to
Right.
add.
Yeah, I think this is much needed. So this is the institutional change which is required in future. And again, to both of you, my panelists, what is the biggest myth if you want to bust about the rare disease on this forum?
Uh,
Let's start with
what is the,
Dr. Prasad first.
yeah.
So I go first. So one myth about, since I'll talk about cancer. It is not that rare cancers are not curable. That is the most important myth. So as I told, if you have a gastrointestinal stromal tumor, for example, GIST, it's a rare tumor, but it can be treated with a pill, and the patient can live with metastatic disease for 5 years. Who will not want to do that? So the most important myth which I would want to break about rare cancers is that rare doesn't mean incurable. So they should get that chance.
Right, right. I think this is what is there, and there are certain rare diseases, and that, as Dr. Seth has said, that they have found mutation for a few, and they are developing the therapeutics as well. So I think this is going to be different for the different rare diseases as well, not only for the rare cancers. Dr. Seth, do you want to burst any myth around rare disease for the public?
I think the myth is the only myth is yes. Uh, the major concern is, oh, there is no therapies there. So, what is the point of making it? Even I know that some of the even adult neurological disorder like Huntington, or maybe the ataxia, or people say, oh, there is no therapy. So then, what is the point of making a diagnosis, or somebody like suspecting with Parkinson or Alzheimer's? But you know that once you diagnose, we know that what is going on, what are the genomic changes that are happening, and we develop the therapeutics. So this myth has to be has to be removed. Even like
Right.
for the cardiologist, you must have seen many of the patients recently, young people, they're dying in the gym with a sudden cardiac attack. When the reason is because I think there may be underlying mutation, maybe there, but the cardiac wall is already weak, and then do the excess exercise, so they just get tired. So this myth has to be removed.
Right. Right. So, on that note, I think we have got to know and we have discovered what is happening on the rare disease front in the India's ecosystem. And I think future is bright, and definitely we have more therapies and more mutation discoveries coming up. And as far as the rare cancers is concerned, they also are having immunotherapies, and orphan drugs are being made accessible. And I think the future is bright, and we will definitely have more and more
Sure.
therapeutics and more diagnostics available in future. With that
That's true.
note, I thank you all for joining us today on this forum.
Thank you very much,
Thank you.
Manisha, Dr. Prasad, this, for the good input. And thank you, all the best, and hope that definitely India is on the right path. So very soon you will see the good results for the rare disease, also for the national data, the genomic data grid. Thank you so much.
Thank you, sir. It is a pleasure interacting with you, sir. Thanks, Dr.
Thank you.
Manisha.
Thank you. Thank you.
Thank you. Thank you.
Thank you.